No voice. Hello. Hello, we can't hear anything. Hello.
Hello. Good morning, ma'am.
Good morning. It has started.
No, ma'am.
Okay. So I think we should start it by right now. We should start it. Start. Hello.
Safe driving mood पता नहीं क्या लिख के आ रहा है.
Dharmender, hello. Hello, Mr. Dharmender. Hello.
Yes, ma'am. Yes, ma'am.
We can't hear anything. Have you started the presentation? Then we can't listen anything. आवाज नहीं है बिल्कुल भी.
Hello. Yes, yes.
Hello, good morning.
Audible? Good morning. I'm
Yes,
audible.
yes, sir. Yes, sir. You are audible right now,
Yes,
sir.
right now you are audible, but
I'm sorry, I didn't unmute and I went to full screen. So that was the reason. Okay. So let's start.
Okay.
So good morning and welcome you all. And I'm thankful to Dr. Kaur, Principal of State Training Health Institute, to give me this opportunity to share with this. We did last time more than 50 plus webinars, and in this coming series we are going to have more of them. So this presentation is dedicated to all our health worker colleagues who have lost their life during this pandemic, because we know that this time is very, very, very serious one, and healthcare workers are the only one. So we know that what has happened over last approximately, we talk about at least 1.5 months. So these are the latest statistics we can see day before yesterday. So we are seeing a very large number of cases, probably for 3-4 days, it is the highest in the world. That's one of the reason. And with this background, I like to talk something. But before I move on, I like to request everyone, please do listen, reveal appropriate, and try to make an understanding of right things. So we'll discuss briefly about epidemiology, few definitions, what is risk categorization in pediatric age group, and what are the high risk features.
Safe driving mode.
So is Dharmender everything fine? Hello.
So you continue, it's okay. We all can listen very well to you. You can continue.
Okay, I'm hearing which some interruptions, so that's why I wanted to talk. Everything is fine. Okay.
No, everything is fine. You continue, sir.
Okay. So right now, what has happened that even in our country, there are reports of new variants, and another one that we call as UK variant. There are 3 more. For variants, just try to learn one thing, that this is a costly affair, and variant are looked into for 3-4 things. If probably one is that this our RT-PCR is not going to pick up. Second is for the efficacy of vaccine. These are 2 important, and sometimes we have more of severe disease like this, like with higher infectivity plus more and mortality. So in mortality, the things are not clear, but it is sure by this time that this UK variant and the newer one, they are definitely having higher infection rate, what we call as or not. So as we move on, this is the outlay of my presentation, starting from epidemiology to prevention of COVID-19 in the pediatric age group. So today's session is devoted to children. Why we wanted to talk? Because more and more children are now testing positive. This is being seen in our OPD also. And important to learn and remember is that the majority of them are asymptomatic or mildly symptomatic. And another issue is that sometimes parents, both of them, they are getting admitted to facility, or as we know that this is a time for nuclear families, so children are to find themselves or at the mercy of grandparents, or if there is good neighbor. And there's one more term which we are now learning is COVID-19 orphan. Then this will lead to trafficking of children and abuse and misuse. And as we move in this presentation, we will come to know there are a number of studies which show that there are very emotional and behavioral traumatic issues. And few of them are starting even throwing tantrums. And remember one thing with a word of caution, you must be seeing number of messages on WhatsApp. So please, nobody can adopt a child who is a COVID orphan. It's illegal. There are set norms, and probably in the coming months, the government is going to relax those norms of adoption, but it has to the designated agency only. So please bear all this in this time when we're looking into more and more of information. So earlier, when we were during last year, there are a number of studies. There were issue whether the children are contributing to the spread of the disease, and by the mid of year, there were around 7 studies who looked into. Of them, 5 looked into intrafamiliar and close transmission, and it was their view that child-to-child transmission or adult is there, child-to-family member transmission is there. Was there, but it was at very low rate. So this is important to remember. And remember that anybody who harbor this virus can transmit this one. So it's to look into whether these are the teachers or the students at the places. And we are all talking about second wave and upsurge. So what is the reason? Probably these are the probable epidemiological explanation. We lowered our guard because people started moving out. It was almost an year people were not moving out. There was totally number of facilities were unlocked. Mass gatherings were allowed, and even despite there some restrictions, people were beyond that. And at the same time, we also forget to adhere to social distancing of 2 meters and correct use of correct mask every time. And another, as I discussed, there is some concern that there are new mutant strains which are probably very highly infectious. What has happened due to this? There are a number of studies which are showing that there are studies which are showing that we are seeing number of children, because as we are also seeing more number of children in OPD and indoor as compared to last year. So view आ रहा है. Okay, fine. So just to continuing that, we are definitely seeing more number of and the reason is that there is no absolute number. It is being shown. We were having a discussion in the ministry official yesterday also. So in less than 20-year-old, it's around 12%, which is almost equal to the last year. So we know that this virus is very highly transmissible, and up to last year this R0 was 2.6, and this time it is this mutant strain, it is around 3.8. So this is the basically the how this virus looks at under microscope, and there are certain characteristic features in this. So this is basically the lipid coat. Okay, so we can see in this. This is the lipid coat for this virus, and these are the spikes which probably attaches to the mucosa of the respiratory epithelium. With this, and then they are responsible for airborne transmission. So this is another we are going to discuss later on. Another issue is direct spread. This is more one, and we were discussing last year. I'll talk about those differences which are based on the evolved knowledge which has come up during this year. So there is direct spread, and these are aerosols when we do some procedure in these patients. And indirect contact, this was being taken care last year, but now there are a number of studies and revision that it is not much responsible for all this. And this is actually very important, contaminated hands, which are either not clean or we do not take care of hand hygiene. And inadvertently, we happen to touch our eyes and face. So then basically, we would like to get ourselves infected. So that's why there is the importance of regular use of hand washing and hand sanitizers that we'll discuss in another presentation, that which one we should be using, how to do hand washing, and what it is important. So let's learn how this virus is transmitted. What happens when we breathe, talk, sneeze, cough, and even talk loudly or even laugh? So we are going to lead to these aerosols. This is a normal phenomena when we talk about, and we have two types, smaller and large spray droplets. So large are going to lead to around beyond 6 meters, and the smaller one, they were going to fall between 1.5 to 2 meters. So this is basically an area, and now there are a number of publications which are emerging that even large spray droplet may even be responsible. So this is based on the size of these particles. So actually what we talk about in the lighter vein is size matters. So that is very important here. These large droplets, they remain only for shortly in air for very less time, and disperse over a short distance of around 1 meter, and that is between 1 to 10 liters. So this is basically the mode of transmission of this disease. So one need to look into all these aspects. So far the knowledge what has been gathered and is internationally accepted, that we have droplet airborne transmission and contact transmission. So droplets are large and small, as we talked about, that contain the virus, and when we are in the vicinity of an infected person within 2 meters, and smaller droplets and particles, they remain suspended in air over larger distances and are responsible for the droplet transmission. So up to last year, say in the mid of the pandemic, it was being suggested that contact transmission is there, but now the evidence is emerging that this contact transmission is not so important as one of the etiological factor in the transmission of this disease. So what is going to happen when somebody comes in contact with this virus? So it is basically the time what we call is average 5 to 6 days, but it can range from 1 to 14 days. So remember, incubation period can be as short as 1 day. And then important points come, that how long somebody who is harboring this virus has come in contact, how long he or she is infective. So it is said that the most of the time person is infectious when they become symptomatic, and that will depend indirectly on the severity of symptoms and stage of illness. And it is been seen that higher levels of virus are detected in the people with severe illness. And it is also well accepted by this time that people are going to spread this disease before they become symptomatic, and 24 hours prior to onset of the symptom is a period when one person who is harboring this virus is highly infectious. But remember at the same time that this virus can be cultured, as we know, up to 8 days, because in some individual may be detected for very long period or longer duration, but this is not indicative of that very particular person is infectious, because what the test we are doing, they are probably basically looking just a PCR based test, and what we do, we based on that, we would like to, based on that we can get this positivity, and that is not a sign that person is going to be infected one. So one need to be looked into, and that's very important. As we move in this pandemic, more and more information is coming. So remember, there are large respiratory droplets, as well as there is inborn transmission. So it's very important when we are taking care of like this ventilation, air filtration, especially those who are working in ICU or in summer months where the temperature is very high. So it's recommended that if it is feasible, then one should not be using those air conditioner in the closed room. And if you are using air conditioner, then probably be careful that one need to take care of adequate ventilation, in the sense it is recommended that there has to be exhaust fan who are going to take out all the air from that very particular area, and try to examine a patient as much as possible in an open area, not in the crowded places. It also depends on the crowd and as well as amount of the time spent in indoor. So that's why it becomes more and more important, especially for the healthcare worker, to use the mask whenever they are in indoor working. And when we are working with the mask, we will discuss in some time. So timely do take care of quality of mask and fit, because I'm meeting a number of people because of 95 they are washing it, and washing is not recommended. That we will discuss in another presentation. So when this disease came initially, there was not much of evidence that what is happening, but this was published in Lancet last year. So this one basically cartoon suggests that if this is, we take as day of onset of illness, and by most of the time, this end of first week, most of the patient gets admitted, and they will have shortness of breath or hypoxemia here, shortness of breath on day 8, and ARDS 9th day, and by 10th and 11th day, they would qualify for admission to the ICU. So this disease has got a very classical period. So this is very important period to monitor these patients, and if monitoring and then adequate advice to them when to seek the hospital admission once they have been diagnosed. So let's try to look briefly into the symptom, and remember just one thing: this virus is so notorious that it can present like in involvement of almost all systems so far. So most important has been the fever, dry cough, shortness of breath, sputum, fatigue, and myalgia. Sometimes people are having very severe headache and myalgias only. They are not developing fever, and if testing is done, because of keeping some point, they are turning to be positive. And it is suggested that in older age group or geriatric population, if there is unexplained change in the baseline, then probably these are the symptoms. The less common are sore throat, headache, arthralgia, chills, nausea, vomiting, nasal congestion, diarrhea, and hemoptysis. But remember this time that what is happening is right now is this UK variant and other variant. So more and more people are presenting with severe headache or myalgias and arthralgia. So one cannot take this, what I said is, this is based on the what we were getting up to the last time. So one need to look into that. And there's one more very susceptible population, which is people beyond 55 and 60 years, what we call as vulnerable individuals. And at times they may not be having any classical symptoms, or symptom may be just minimal. So one needs to take decision based on the clinical judgments. And it's reported that we need to be looking out in this genetic population, altered or atypical symptom, like if there is sudden change in the mental status, or there is increased confusion, or there is already some underlying condition of lungs, and we see acute or rapid worsening, the loss of appetite and increase in fall. So remember, virus can give rise to any sort of symptoms. So let's try to look into primary focuses in children today. So in children, what we can have, they present either with acute respiratory infections or GI symptoms, and sometimes it is systemic features like shock-like presentation. So it is important to remember that primarily we see most of the time we are seeing acute respiratory infection, what is pneumonia, and this one what we call as MIS-C. You must have heard, there must be few reports in the newspaper even. So it is again important to be careful of that, because it is being suggested and discussed that as we are seeing, we are going to come to the end of if there is some reduction or flattening of this wave, then we may see after 4 to 6 weeks, we may see this sort of presentation in these in the pediatric age group. So one need to be careful, especially our pediatric colleagues. And there's also one more issue, that downscaling regular child and maternal services definitely is having some adverse effect on the children. And closer schools, it has led to some disruption in the learning. There are mental health issues, and because parents are not able to work, so there are economical issues. So this pandemic is probably going to affect everyone in some or other way. So we know this time that this infection the kids are getting is from the parents, because or from the neighborhood, from their friends, if when the schools were closed, but they were going to playgrounds. And remember, so far there is no documented evidence 100% that this virus is transmitted vertically or through the breast milk. So implication is very simple. As a baby is born to a COVID positive mother, the baby will stay with the mother, and the mother will provide her milk to the baby along with the adequate precautions, which we have discussed, and we may be discussing in the coming webinar. And if there is a positivity in a neonate in any time, so probably it is because of either some caregiver or from the contacts. Children, it was earlier said that as infect others, there is not much of evidence on this, but it is again another concern is that it has been documented that there's a prolonged shedding through the fecal material, so it's important to understand. As how much disease burden is from the children, it is around 5 to 10% of the global disease burden. Now they are up to 25% of the total population. So it is because they are getting less exposure, and we have less of outdoor activities, and also there's nature has provided them some protection, what we call as less susceptibility. We'll discuss their possible explanation briefly. And another, this is very important because most of the time this disease is very mild or asymptomatic in children, so hardly they are tested. Another plus point in this COVID virus in the children is that that chances of hospitalizations are 20 times lower for the children as compared to adults. But remember, this second wave, what has happened that more of adolescents, that is beyond 12 years, are getting admitted and even in ICUs, as per the data which is emerging from the different centers which are taking care of these patients. And fortunately, the mortality rate is also very low. And it is being said that those children with underlying chronic illness, their deaths are more. And when we look into the overall data last year, it was few hundred deaths as compared to the million deaths in the adults, and unlikely to be super spreaders. So why the children are doing better in this as compared to adults? In addition to like their school are closed, they are less asymptomatic. So it is said that there are ACE2 receptors are immature, so virus is not able to attach and enter. And we know that this coronavirus are not new. There were earlier 6 generations which were already in circulation. So probably there could be some cross immunity. And it has been also being proposed that this universal use of BCG and MMR vaccine has also led to some protection because of the robust immunity. Count, as we know, up to 6 years, predominantly these are the lymphocyte. They are higher in normally, so probably that's one of the reason it's going to take care. And as compared to that, the children are having less of comorbidities. The lungs are also healthier, and there is no smoking. So these probably all these explanations are leading to less number of disease in the children, and severity is also less. And one more thing to remember that when we are looking or taking care of these children, whether in wards or outdoor, around 50% of them may be asymptomatic. So one is need to be very careful when we are examining. What are the symptoms? It could be fever, cough, GI manifestation. These two are very common. And in children, we have less reporting of loss of smell and taste. And there are a few case reports. I'll show you the diagram that they do present with skin rashes and even neurological manifestations. So what is severe COVID? This is just what we look into, that in adults, it is said that 60% of adults may have this symptomatic. Patient may present with dyspnea. And as compared to children, now let's look what is happening in children. So around 30% are asymptomatic, acute ARIs and 33%. Mild pneumonia, we will discuss that which cause mild pneumonia, and severe pneumonia, as you can see, is just around 1%. So one need to take care. These are the basically presentation. So remember from this that majority of children will present with mild pneumonia. So that is the most common presentation. And it is also being discussed that the presentation is for pneumonia is almost similar to the adults. And this is a different entity, which we'll discuss sometime briefly in this slide. But remember that as we move on more and more during this pandemic, the new syndrome may be still evolving because this virus is moving few steps as we are just planning to contain this virus. One need to be careful and take care of that. So in adults, it is primarily the interstitial pneumonia and tissue damage, which is mediated by the host innate immunity is responsible for all those manifestations from the 8th day of illness. And so far we know that in children, this is mild illness. And this is a multi-system inflammatory syndrome, what known as a MIS-C. This is a different entity, and this is being reported almost in all countries from the world, and is seen after 4 to 6 weeks once cases in the adults start declining, and we will get evidence for that. We will discuss later on. Now the question will come, when to test a child for COVID-19. This is very important. So there are few definite indicators. If there is history of contact, but remember that it may not be available most of the time, and contact may not be asymptomatic, and we get influenza-like illness, severe acute respiratory infection. That's definitely one of the indication to test for COVID-19. And as we discuss later on this, if we suspect PIMS or in these children, then because there are indications before any procedure in the hospitalization or before any hospitalization. And when we children present non-respiratory symptoms, as we said that diarrhea is also one of the common presentation, then it is a judgment of the clinician who is examining that patient, and fever if there is without, there are no respiratory manifestation. What are the facility which we are having to confirm the diagnosis? So we have 5 things. One is a molecular diagnosis, antigen detection, antibody detection test, some lab test, and radiology. So we'll discuss briefly one by one. In molecular diagnosis, we have RT-PCR based or nucleic amplification test, and then CRISPR, or what is also known as FELUDA. So what is virologic testing for SARS-CoV-2 infection is? It is for high priority for those which are presenting with the symptoms, healthcare facility workers, and those agents which are working in long-term facilities or where there is congregate living settings. Priority to whom? Prioritize. So it is recommended that we prioritize those with potential COVID-19 suggestive of symptoms of COVID-19 infection. That is, we all know fever, cough, shortness of breath, and a person without symptoms who are prioritized by the health department or by the clinician, as we know, because now there are a requirement also to look into the RT-PCR testing. Once we have done the test, then it's important to interpret the diagnostic test. So we'll spend some time on this slide. So this is the natural history of this disease. So basically, this is the 1 week prior to the onset of manifestations. So before the symptom onset. So this is taken as a 2-week period because the incubation period can be as long as up to 2 weeks, from 1 to 2 weeks. So in majority, it is around 7 days. So remember here, the patient is asymptomatic, and if we offer any test here, probably he or she is going to be tested as negatively. So what is going to happen? This negative testing is going to lead to misdiagnosis. So this is very important that when we are planning, and this pandemic, as the surge is there, the evidence is emerging is that even the patients who are being tested with like unusual manifestation, like very high grade fever with chills and rigors, fever is only responding partially to the paracetamol. If you happen to test them during first week, they are turning to be positive. So now what happens between first week? This is a time. So they are going to be tested positively by PCR, positivity up to this time, and by end of 7 to 10 days, there is going to be antibody protection. So if we happen to do the this PCR testing this time, then majority of them they are going to be tested negative. So this antibody production will start, and this will keep on up to 6 to 8 weeks. So what importance is that if you happen to do the nasopharyngeal swab, you can appreciate this blue line. So this nasopharyngeal swab can be is positive before up to 2 weeks after the onset of the symptom. So it is recommended that after one should be try to take it after 5 days of the onset of the symptoms. We have this bronchoalveolar lavage or sputum, which is can be seen up to for 90%, but it is an invasive procedure, so it can stay for a long time. And stool PCR, this was also recommended, and in addition, now people are working on estimation of this virus or confirmation of virus from the saliva also, and in near future we may get those new tests. And these are the IgM antibodies. They're going to fall by around 6 weeks, and Ig they rise by end of between 2nd to 3rd week, and they are going to be detected from 3 to 6 months. So this is basically the virological pattern in this virus one need to look into. So what are the tests and on what sample we are going to look into? These are molecular and antigen tests. They are performed directly from the sample obtained from the respiratory specimens, which we had been doing for last 1.5 years. And if we wanted to do like a ball, that is lavage, so it should be collected with proper PP and precautions. And important to understand is that the sensitivity of positivity of this test varies with the site of collection. And as you can see here, it is more than 95% for lavage. And when we look into sputum and nasopharyngeal swabs, it goes down, and nasal swab is 20%. So that's why we would like to take a combination of both of them. That's a combined one. Saliva, as I said, is also going to be taken care in the coming time. And it's very important to transport these swabs once they have been taken in a transport medium in a recommended temperature to increase the yield of the specimen. So these are basically a cartoon which show the diametric presentation of this virus. How does it look? And like this electron microscope, and these are the sites probably which we can use for testing. So just to continue with the molecular method, what is RT-PCR? We all know this is RNA virus, and this is basically based on amplification of 2 or more target genes. Why we want to do the genomic analysis, but sometime we may be missing because the few reports are coming, so we may be missing. So one need to look into, and it is suggested that it has to be reported positive if all the genes are able to amplify. And at the same time, we look into indirectly viral load, what we call as cycle threshold or CT values. And it is suggested that if CT values are higher, then the if viral load is higher, then the CT values are lower. But remember, this is very important to understand that even you can see there are a number of newspaper reports. People are looking and ordering for the CT values. So remember, so far the evidence is the CT value has got no predicting anything for the severity or outcome of the disease or for the infectivity. It is said that there may be some role, but which has not been proven so far. Again, the CT value will depend on the method of collection, type of kit we are using. And we have these 2 types of kit. Either we are using this TrueNet or RT-PCR. So what is happening as on today is that we are looking for the sensitivity, specificity, because what we are doing a test, we should be knowing that what is their sensitivity and what is their specificity. So it is around 67%. And again, very important that it will depend upon the site of the collection. It is said that nasopharyngeal is better than the oral, and also the timing of the collection. That's why we say, we looked into that slide, that what is the right time to look into. If we happen to order it in the early in the incubation period, negative one, that the patient may be harboring and transmitting the virus. And along with the method of collection and transportation, I'm not putting those pictures here because we have less of time. Otherwise, people are collecting the swab from the back side. That is not recommended, even from the side. So it is recommended that unless a patient winces, you mean that show that the specimen has not been collected in a right way. So specificity is very high. And if a child is asymptomatic, we are primarily discussing in children. So positive swab may show that he is pre-symptomatic or asymptomatic carrier, or is already recovered from the asymptomatic illness and in the post-recovery phase. And rarely it could be false positive also. So repetition of tests, as on today, there's no documentation, but there's no guidelines, but we strongly suspect. Then one need to, in severe cases, it is suggested that those in ICU, some hospital are practicing that they will definitely like to move out these patients from ICU to recovery area. So they would like to do one more testing. Then this is basically a very important tool available with us. And at the time, because there are a number of advantages as we discussed. One is what we call as briefly as a rapid antigen test of RAT. So from where the sample is again the same for RT-PCR, either we take from the nasopharyngeal and respiratory samples. It is known as POCT, that is point of care test. Cost is also very low. And this is the biggest advantage actually. Within 15 to 30 minutes, we come to know about the status of that very particular patient. But remember, there's one more rider here. This has to be done on site within 1 hour of the collection of the sample. So if we should be, if having more and more of backlog, please try to prioritize and accordingly collect the samples. And with just 15 to 30 minutes with the naked eye evaluation, we can say whether it is positive or negative. Specificity is very high, but remember one thing, sensitivity is low. So what does this low sensitivity reflect here? This reflect here that if test comes negative and we are suspecting that this patient is having COVID-19 infection, then these patients are to be evaluated by RT-PCR. So what is current diagnostic algorithm? If we are suspecting COVID, first we have to offer a rapid antigen test to that patient. That has to be again collected in a given way, and as said, within 1 hour the sample collection, and if it is negative, then one need to do the RT-PCR. Then we have third modality, that is basically the antibody testing. When it is done basically one, we are looking for the serological evidence, or we have one more condition that what we known as PC in children. So it is looked into that. So as I discussed earlier, that this starts by the between first and second week of infection. Initially it is the IgM and then IgG. This IgM is going to be there for around 8 to 10 weeks, and then IgG can be 3 to 6 months. And so far time we know that IgM is less specific, and it definitely shows cross selectivity with the other coronavirus 1, 2, 3, 4, 5, 6. And we have different kits. It's very important to look into the sensitivity and specificity and recommendation by CDC and FDA, because these kits are very sensitive to the temperature, so one need to look into. And we have either we can look isolated for IgG, both IgM and IgG antibody test. And this sensitivity and specificity of evaluation of these antibody basically depend upon the kit we are using. And when we are talking in antibody testing for children, is basically for the PIMS. It is a syndrome which is a specific condition seen in children. And please do remember those of our colleague, those where there were number of posts in the WhatsApp. Even after 1 shot of vaccine they were doing, then after 2 shot of vaccine. So as on today, there are no parameters to say that if somebody has got 2 shots of vaccine and he or she gets himself evaluated for antibody, that is going to show the level of protection. One should not be going for that. In addition to this, these PCR and serological based tests, now we have we can take the help of laboratory parameters, because there are certain changes in hematological and biochemical parameters which are based on the severity of the disease in children. And remember that in mild disease, these tests may be normal in children. But when we are looking for the severe disease, we have lymphopenia, neutrophilia, and raised neutrophil and lymphocyte ratio. Raised CRP, but normal CRP doesn't exclude, but this raised CRP, if it is beyond 5 and 50, depending, we will discuss later on. PCT, raised level may suggest bacterial infection, but I'll put a word of caution here. This test is very sensitive one. So how we are taking the sample, during what time and after what time, and what is the facility in the lab, based on that it depends. And the raised levels of values are very variable. There's reduced platelets less than 1.5, elevated liver enzymes, and serum sodium around 135. And if we got elevated D dimers, ferritin, CPK, LDH, and IL-6. So based on LDH, again, LDH and pre-calcitonin, these are very sensitive tests. So this will depend actually basically upon how with the kit we are doing. So one more word of caution here is that we have to take all these tests into toto, not based on the base of a single test. We are going to make a diagnosis of COVID-19 in children. Radiology, definitely it got a role we will discuss, because we recently saw there are a number of publications and information and cross information going on. We definitely know CT is more sensitive than X-ray. And these are the classical finding in the CC. They are probably subpleural and lower lobe ground glass appearance, which is very classical disease. And in children which have been exposed to the CT, the changes has been milder one. But remember, these are not specific. But one issue is there, suppose I strongly suspect COVID-19 in a child, and their RT-PCR is negative, or it is not available due to some reason awaited, and in the meantime, both RAT and RT-PCR is negative, is not available, or report is awaited because, and there is a rapid deterioration. You want to make a diagnosis of correct management, then definitely CT is helpful. That is one. And remember that this is the basically concern in the pediatric age group. So why? Because the one CT scan gives exposure to around 300 to 400 X-rays. So that's a very important issue. And as we are dealing with age, so it's very important to minimize, because one HRCT will give exposure to around 300 X-rays. Now, after looking into all these different tests, now look what is the algorithm so far to make a diagnosis. If suspect, then do the antigen test, and if RAT comes out to be positive, then the story is very simple. Nowadays, on the other hand, this rapid test is negative. So we discussed earlier, then what is the next step? One has to order for RT-PCR. After RT-PCR, we can have both situations, either it is positive or a negative. And if positive, the things are to patient goes, and sometime it could be because sensitivity is by 67%. So now we have to take help of CBC, XHS, and if we rarely, very rarely, the CT scan. And definitely want to look into PIMS, then we need to do antibody test. If we want to plan antibody testing, it has to be done after 2 weeks, and the test needs to be read with. So one liner that if we have made a diagnosis of COVID-19 based on this molecular or RAT, there is, as on today, in pediatric age group, there is no additional blood test or chest imaging are recommended. Now, what we are going to do? Once we have done,
Please mute yourself. People are disturbing. No disturbance should be there, please.
So in between, I'm having some sound. So please, I will request the host to mute all. So this is basically very simple suggested format for children. So this is all information. So how we are going to look into, so this we are going to share with the principal of training institute this performer, and so just give me a minute. I would like to mute one of the participant. So what I was discussing, this is a important format, and based on that we make a diagnosis as we move on through the presentation in the coming, that what are the values. So look for the respiratory rate. We are going to discuss what are the age specific and SpO2 monitoring in the room here. And there are certain high risk factors starting from cardiovascular disease up to obesity, because it is said that BMI more than 2 standard deviation is associated with higher morbidity and mortality. So we need to look into when we are looking into the children. And These are the criteria for home isolation. So we need to look into, after discussing with the parents, into all this, which we are going to share. Now let's discuss, because we have mild, moderate, and severe disease in pediatric age group. So we'll discuss briefly their clinical features and management. So most of the time, the children will present with influenza-like illness in mild disease, and which will be having only not having respiratory difficulty. That is, neither the respiratory rate will be normal for the age, and there are no chest indrawing. And the oxygen saturation will be beyond 94%, more than 94% in the room air. So based on this, these are the criteria we all know, because as per the respiratory rate guidelines, as we look into IMNCA guidelines, so it is the same. Remember at times that not 100% of the children are going to run fever or GI symptoms, so one need to look into. And if you do some examination of throat, so they will show the evidence of congestion, but it is recommended as on today that unless it is really important, then only one has to do the throat examination, that even after observing all the IPC precautions. So when a patient with mild disease need to be taken into COVID-19 care facility, if home isolation is not feasible, like that is small house, there's overcrowding, and parents or say a high risk patient are staying at home, and their facilities inadequate or far away from the medical facility. And if a child is having immunospread or chronic disease like under treatment for leukemia or something like that, then the children should be in isolation home, isolation COVID-19 care facility. It is recommended that the environment should be child friendly, and if it is possible, then we should allow the parents or attendant to take care of the children with adequate proper PE. What are the recommendations for guidelines? It is balanced diet for take care of nutrition, plenty of warm fluids for take care of hydration, rest, deep breathing exercises. There could be that could be displayed on the televisions, and the room temperature has to be ambient one. Before we send a patient for home care, so what is need? It is recommended to explain to the parents to maintain a monitoring chart. They need to count the respiratory rate. We need to tell them in a 2 to 3 times in a day when the child is not crying or child is calm. And we need to tell them by video that how this chest indrawing appear, what is nasal flare, what is a bluish discoloration of the nails and mucous membrane, or if extremities are cold, they can find out. And they need to be careful for the urine output. And this monitoring of saturation is very important, because we had those handheld pulse oximeters, and based on that it's 94 or 92, and they should be provided a contact detail to whom to contact in case they want to discuss something or they find a deterioration in the vitals. So when a child has to be brought to the hospital for when this child develops breathing difficulty or fast breathing rate, there are chest indrawing, bluish discoloration, or the child has become lethargic, the activity is reduced, is not taking feeds, the sensorium is altered, or seizures. And if you look into for the hypoxia, if it is monitored in a correct way, then saturation is less than 94%. So this is a chart which the parents are supposed to carry with them, and we need to tell them. Just to summarize the mild illness, in home illness, it is supportive care, rest, paracetamol, that's only the drug which need to be given. And remember, it has to be given in adequate doses of 15 mg per kg per day, because that's the reason, because most of the time we don't give, and it can be repeated between 4 to 6 hours. So avoid non-steroidal anti-inflammatory drugs, especially those with underlying chronic kidney disease. Now there is no evidence, but it is shown that paracetamol is going to take care in more than 95% of the patients. There is no role for cough suppressants or montelukast, and if parents want, or child can take, then warm saline gargles. And honey, it can be used safely about 2 years, Beyond less than 2 years, there are chances of poisoning, so one need to be careful. And at this stage, there is no role of antibiotic. So these are the cutoff when we wanted to label a child with a moderate disease, fast breathing, beyond 60 minutes for less than 2 months, and beyond 5 years, it is up to 30 minutes. So this chart need to be displayed, and there are no other signs of severe pneumonia. So based on the just a respiratory rate, there are no signs. So these patients can be managed either at a dedicated COVID health center or district hospital, and if need be in a medical college. But I understand that all medical colleges are overstuffed. So one need to take care either in DCHC or in a district hospital. So remember what we discuss, all those investigations, these are not required in all patients. Based on case-to-case basis, one can order hematological and biochemical investigations, ECG and chest imaging. And if need be, if saturation is dipping below 94%, then we need to supplement oxygen. I'll discuss later on. And if it's a non-patient of asthma or comes with wheezing, then it is recommended that we give meter dose inhaler with spacer after adequate training. There's no role for antimicrobials to be given empirically until unless we suspect bacterial infection. And if you want to give, then it has to be as per the local antibiogram. But if it's an immunocompromised child, then less than 5 years of age, then one can justify the use empirical antibiotics. And if there's very rapid deterioration, because sometimes what is seen in this disease is that from moderate to severe disease, they deteriorate within few hours. So one can take a decision to start with the steroids. So what is the specific treatment for moderate COVID-19 as on today? So as on today, there are no established therapies for COVID-19. So one thing is very much clear, there is no known for in children chloroquine or hydroxychloroquine, ivermectin, or like favipiravir, immunofenavir, remdesivir, lopinavir as antiviral agents, and immunomodulator like tocilizumab, interferon B alpha inhalation, or convalescent plasma infusion. So these are just as been experimental basis and tried on those patients who land up in ICU. So one need to look into that. So how we are going to manage a patient of moderate COVID-19? So we need to look into clinical parameters like heart rate, respiratory rate, blood pressure, and SpUT, and keep a watch for work of breathing and oxygen requirement. And as we discussed earlier, based on individual case-to-case basis, order CBC, platelet, absolute lymphocyte count, and kidney and liver function test. And if we have got, then we are going to, patient has got moderate to severe disease, then CRP, D-dimer, and ferritin if they are available. And remember, in a DCHC or a district, where when the patient develops increased work of breathing, and we look, there are instability in the heart rate or blood pressure and SpO2 dips, or the oxygen requirement increases, these are the indications for referral to a higher center. So this is just how we are going to look into. And remember one word of caution here: during the second week or end of first week, if there is a rapid fall in saturation, one can use the steroids. So what are the good clinical evaluation criteria? From patient should be afebrile for 6 days from the onset of illness. And remember, two determinations are very important. There's no need for oxygen on clear improvement of respiratory failure. CRP less than 5. LDH is normal if you have already ordered it. Lymphocytes should be more than 1000, and absence of radiographic progression. So these are earlier suggested criteria. Based on that, we can take a decision to send the children home for moderate disease. Now we are in the third part of the disease, that is severe disease. What these patients may present as severe pneumonia, ARDS, or sometimes they can present like sepsis, septic shock, MORS, or even malaria. This pneumonia could be seen with sepsis, and the SpO2 is less than 90%, and in association, or sometimes there could be cyanosis and grunting and severe retraction. So these are all signs of severe pneumonia. So this indicates a very severe illness, and this patient will qualify or admission to a setting where ICU facilities are available. So either with ICU or high dependency unit. And this patient definitely needs investigation for thrombosis, HLH, organ failure for appropriate investigation based on the consultation with the pediatrician or the infectious disease expert. And then they can take a decision regarding the steroid or remdesivir, as well empirical antimicrobials. But most important is use of oxygen therapy and restrictive fluid therapy. And if there is support like a renal replacement therapy, that needs to be taken care of. Or if there is need for support in the form of hypertension, then we need to take care of with inotropes. So this patient definitely warrants admission in SDU or ICU settings. So briefly, something about oxygen therapy. So when if saturation is beyond 94% in the room here, nothing to be done. And so the target, what should be set a target if there is falling the less than falling than 94%, and during resuscitation we are doing, it should be more than 94%. And if those children are stable or recovering, then beyond 90% is good enough. Never make an attempt to go beyond 95% or make it 100%. So we will waste the resource, very useful drug in this pandemic. Everybody is fighting for this drug, so we need to use it judiciously. That's very important. And what are the devices? Nasal prongs or cannula are preferred and recommended in pediatric age group because they are well tolerated. And if you want to take care of risk of aerosolization and droplet spread, then one can use a surgical mask or put over this device. Sometimes what happens that even with the prongs and SpO2 may not be, patient may not be able to maintain saturation, then we have other devices which should be used. It should be available, like face mask at a flow liter of 5 liters per minute, which is equivalent to giving FiO2 40 to 60%. Oxygen hood at flow, this should be probably, because we are going to have more of wastage here, because this gives FiO2 30 to 90%. Venturi mask and non-rebreathing mask at flow rate of 10 to 15 liters. So this face mask at a flow rate of 5 to liter and non-breathing mask at recommended, because with this we are going to have minimal wastage of the oxygen. So now we talk briefly about high flow nasal cannula devices. So these high flow nasal cannula may be used preferably over CPAP and BiPAP if, as per the age, we are not able to maintain the target saturation. So how to start? Start a low liter of 0.5 to 1 liter per kilogram per minute, and it gradually one need to increase to 2 liter per kilogram per minute to having a look on the saturation. And remember to use the minimum flow that leads to a target SpO2 between 90 to 94%. Don't make an effort to increase beyond 90 to 100%. And at the same time, these patients, because these are going to may deteriorate rapidly, so it is recommended that we are going to monitor all their vitals and work of breathing. And one need to wait or evaluate these patients for 1 to 2 hours. And if there is no improvement, then escalation support. So it is recommended that when we are using high flow nasal cannula devices, then 3-ply mask should be important. So what is severe illness? Just to briefly learn, because this is not for those who are working in periphery. If those ARDS, mild ARDS, and these are all basically our features of shock. So this is a severe illness, and one need to be very careful. Briefly, just to recapitulate what we have done. So children should be categorized, those COVID-19 positive or suspected based on the signs and symptoms, and management protocol as we discussed for mild, moderate, and severe. That is accepted one, and it should be followed one. Infection prevention control measure for all suspected and confirmed cases. This is most important. Mild disease, home isolation with monitoring and symptomatic treatment, only paracetamol. Moderate disease, admit in a COVID dedicated facility, which should be having a facility for oxygen. So we give them low flow oxygen and symptomatic treatment and along with meticulous monitoring. And if patient lands up in a severe disease or deteriorate or is diagnosed late, then admitted in HD or PICU, and oxygen therapy, high flow nasal cannula, and IV mechanical ventilation may be needed. And there is opinion of few of the experts who are dealing that these patients, earlier up to last year, people were rather mechanical ventilation. Some people in infectious disease expert and ICU setting, they would like to take during this research to these patients earlier, and these are the recommended ventilator setting. One need to look into antimicrobials, but remember, most important is the monitoring of heart rate, respiratory rate, blood pressure, and SpO2. Antiviral, tocilizumab, and conventional plasmapheresis, as on today, there is no data in children. So rarely there has been used in some intensive setting. So briefly, let's have 2-3 case scenarios before I briefly discuss the presentation. So this is a 5-year-old who has got high fever and cough for 3 days. And there's no history of family history of COVID-19, but the testing physician has recommended for RT-PCR, and it has suggested positive in oral swab. He has 2 elderly grandparents. He tests positive. And by the time the report of test is available, he has become afebrile as asymptomatic. How are we going to treat this child now? So this case is there because see this line. He has 2 elderly grandparents. So we never know that he may be in a position to transmit because already. So these patients, younger patients who are test positive, they are not to be kept with the grandparents, even whether their parents have tested positive and they are in isolation and other facilities. So it is recommended that child should be cared by the parent instead of the grandparent, because we all know that age beyond 55 with comorbidity is a very high risk factor for development of the care of these children, and the caretaker in the home should wear a mask and practice hand hygiene. While for those mothers, while changing diapers or cleaning after swaddling, they should be using the appropriate infection prevention measure. And if they are sick one, then one need to look for the lymphocyte count and lymphocytopenia. So it's number 1 in home or hospital. We know at this time this has to be in the home, and child will remain with the parents who need to be healthy. The parents are also having some comorbidity because he cannot be looked separately, but if a child is beyond 5 years, he can stay. Then it is recommended that he can be in another room. So what about homeopathic and other treatment? As on today, there is no role. Vitamin C, but I've seen few of the prescription. Vitamin C 60,000 for 10 days. Please bear with me. This is a toxic dose, and the patient will end up with hypotetanus D. So if you want to give vitamin C, then use in recommended doses. Zinc, this vitamin D, vitamin C and zinc can be given. Again, steam inhalation. Number of the patients have developed steam-related burn, so one need to be careful. Azithromycin, ivermectin, doxycycline, hydroxysteroids, no role. Steroids to be used if a patient from the moderate or grade 2 disease land up in grade 3. And when will you test? There is no need for testing. Isolation, as we know, this is standard recommendation for 10 to 14 days. Now we have another case scenario. This is a 15-year-old obese adolescent. The weight was 80 kg. And 10 days back, the parents had tested positive. This adolescent has now come up with fever and cough for last 5 days. And on 6th day, she had become breathless also because her respiratory rate and saturation is dropping. It is now 90% in the room here. RT-PCR was sent from the emergency, and diagnosis by this time we can take is severe COVID-19. So again, because here the comorbidity is there, so this will definitely need a monitoring and admission to a high dependency unit where facilities are available, because she can deteriorate at any time or even may need mechanical ventilation. So this is, I was discussing PIMC. This is a 7-year-old boy. He presented with fever and conjunctival congestion. And along with the rash, you can appreciate over the body here in the adjoining photograph, and red lips. They are tested with antipyretics, but fever persisted. And in this patient, there was no past history of COVID-19 or exposure. He was tachycardic, saturation was 99%. So is this PNCTS? Basically, one need to look into all those parameters, because a close differential is Kawasaki disease, which is also very common. So one need to, you can appreciate here congestion and the rash. These are the different photographs. These patients have been with PIMS. So briefly, this is the most dramatic manifestation of COVID-19 in children. Just remember those we are looking, because this is an emergency and seen after 4 to 6 weeks, sometimes even up to 8 weeks. And it is said that it is due to aberrant immune response. And we are getting case reports, even number of reports from India, and the variable severity. And so basically depends upon either we have a febrile inflammatory syndrome, toxic shock-like presentation as with the staphylococcal infection in all the children, and Kawasaki disease. So these are WHO criteria. Based on this, we are going to make a diagnosis of this one. So, and how to evaluate? So these patients need to be monitored or admitted to a facility where ideally we should have a facility for cardiac evaluation. So one need to take care for these patients, and based on this, these are the standard guidelines. These qualify for aspirin or prednisolone or IVIG along with that. So this is a flow diagram for these patients. And in addition, these patients need very meticulous monitoring, aspirin, and low molecular weight heparin also. So when to discharge and follow these patients, this we'll discuss in next presentation. So now we have one more case scenario. The mother has been detected to be COVID positive on routine testing prior to cesarean. So what I'm going to do here? So what is the mode of delivery of mother? About neonatal resuscitation. So mode of delivery of mother, it's already cesarean sections. One need to take care adequate precautions. Neonatal resuscitation, it need to a separate chamber here with all IPC testing. Testing of the baby, it is now recommended that earlier there were recommendation that we need to test these babies for 48 to 72 hours. Now it is recommended that if baby is asymptomatic, there is no need for testing. Whether baby to be separated or roomed in, now we have a clear-cut guidelines from the ministry and WHO that these baby need to be roomed in with the mother. Breastfeeding versus express breast milk. If it's a term baby able to accept breast milk, then mother has to provide her own milk with taking all those due precaution, use of mask as well as hand hygiene, vaccination as per the routine, and discharge as per the policy of the hospital. So if you would like to quarantine children with COVID positive first conduct, yes, one need to quarantine these children if the child is asymptomatic and for 2 weeks. Then if there's another recontact, again for another 2 weeks. So if child is unable to avoid close contact, then it need to be extended up to 21 days. How to quarantine? If mother is COVID negative, then it is recommended that child, if is younger one, he has to be quarantined along with the mother, and the mother has to take all those preventions which we need to discuss with her, and strictly avoid contact with the elderly and grandparents, or if parents are having comorbidities. So one can take or relax here quarantine period, the use of screen, TV or cell phone, and it is recommended that child should be encouraged to consume fresh vegetables, fruit, and to make up for the immunity. So for our colleagues, please never let your guard down. Test is negative. It can be a co-infection, and if it is a pneumonia, treat as pneumonia or infusion. And if facilities are there, then admit in isolation. And for ventilator, those who are working in isolation, they should be using those filters. And when you're going to intubate in ICU, then one need to take appropriate care. And all universal precautions that has to be taken care of And remember, it is not a diagnostic tool, especially in children. It only helps in those cases where diagnosis is unclear. Isolate these patients, and we need to involve the local expert. Take care of dehydration. Acute injury is also very common in some few of the studies, so one need to take care. And then one should ensure that children and parents who are coming to OPD, they should be wearing the mask. And our colleague, they should be using personal protection equipment, hand washing, social distancing, avoid throat examination and nebulization. Pulse oximetry is mandatory. And there are a number of indirect effects because of lockdown. Number of reports has appeared in the literature. So what these children can see all this, like agitation, fatigue, and everything. So sometimes the children, though most of the time it's going to be a milder disease, they recover only with paracetamol and nutrition and monitoring. So sometimes they can develop a severe COVID-19. So it is recommended that if less than 3 months and beyond 20 years, they might more likely to require admission. But now these are changing. We are seeing more and more 12 years old and adolescents. Any comorbidity like pre-existing pulmonary, GI, endocrine, neurological, psychiatric, there has been shown to increase the risk of admission. And if there is asthma, obesity, diabetes, or obstructive sleep apnea, high CRP, it has been shown that beyond 50, increase order of requirement of critical care. But remember, this disease is not being affected by sex, race, or ethnicity. Now, the reports which are coming from UK and the US, they do say there are certain ethnic populations which are having more of PIMS and high number of cases in children. So when we are counseling those families where the children are having comorbidity, we need to discuss everything and record it. So only key is the prevention and how to practice that. We know that transmission through large droplet and less by the droplet nuclei and fomites. So 3 basic principles, that is social distancing, use of mask, hand hygiene. And if vaccine is available, then one had to go further. And at the same time, to look further adequately for the medical facilities. Children need to take care of pre-existing illnesses. And we need to discuss with every mother to continue breastfeeding and immunization, which are the current guidelines, Government of India and IIT. And even if it's a new respiratory illness like pneumonia and has tested COVID, then the standard guidelines are same. And CT should be used very judiciously. And if you are sitting in a center like DCHC something, and one need to recognize, stabilize, and only then refer along with the facility for oxygen admission devices. And one need to keep oneself updated, beware of fake news and updates. And all those government notifications which are being issued and time, one must refer to them. Majority of infection in children are asymptomatic. And as far as possible, use telephonic and digital consultation. And as we discussed, if children has come in contact with a positive patient, then they need to be quarantined. So far the evidence in the literature is that it's a relatively mild disease in children and newborn. And we don't have much or specific data that children are also super spreader. Treatment is mainly supportive and symptomatic. And this MIS-C definitely has emerged as a distinct entity, and one need to take care to suspect and manage. And by this time, we have indirect effect of COVID-19, as I discussed, because a few of them have become COVID orphan and so on. Parents are there, their loss of livelihood, not going to school, not playing, number of issues. And COVID-19 vaccine, though yesterday there was a report that it is going to be used because they have not been evaluated. But again, with emergency authorization, we may see their use in the coming months, as we are going to first take care of the requirement of above 18 years and 45 years. So my request to everyone, if you need to step out, is wear a mask properly one. And if you show symptoms, immediately isolate yourself. And there's no need to panic. Most cases of COVID can be treated at home. Get yourself tested. And if you are not get yourself vaccinated, please register as early for vaccination and wait for your turn and complete the vaccination. With this, I like to thank you everyone who having for this patient cleaning, and if there are any questions, I can take them.
So they are not asking any questions. I would like to ask the preparedness of the people for this type of patient. जिसको थोड़ा severe infection
Just give me a minute. I am not. Just increase the volume and then I'll get back to you.
Okay.
Kindly repeat your question.
So my question is, if something seriousness happens to the patient, the child with the COVID positive patient, then what should be prepared at their level? हमने ये DCSC सब doctors को involve किया है इसमें. So how they should be prepared to take that patient?
So as we discussed that classically this disease is mild in children even with COVID-19. So based on that age, if there's no comorbidity, there's nothing to worry, simply monitoring. We just pointed out that one need to record the respiratory rate, and everybody is now being provided with a pulse oximeter. SpO2 has to be beyond 94 or 95% in the room here. And we just need to keep a watch on the temperature. We generally subside by between 3 to 5 days. And if there's a temperature, one need to use paracetamol in 15 milligram per kg per dose in adequate doses, and it can be repeated after 4 to 6 hours. One thing. Secondly, I shared that chart. One need to monitor this respiratory rate, SpO2, heart rate, these four, and if facilities are available for blood pressure also, these parameters. And if there is drop, if you look into if respiratory rate increases, or as I discussed that there are signs of pneumonia from moderate to severe appear in those patients who are in moderate. They appear like there is a cyanosis, saturation is less than 90%, despite low float, 1 to 2 liter, it is not improving, or convulsions, some neurological manifestations, then probably this patient is going into the severe disease, they need to refer. Otherwise, hydration, adequate diet, nutrition, paracetamol, that's going to do wonder in pediatric patient.
One thing more, sir, when they have to refer, I think so they don't have to refer in their own vehicle. They have to call help, or they have to refer in an ambulance.
Yeah, I think we have got a
particularly they have to take care of that. So this message
will depend upon the place. It will depend upon the place.
Yeah.
Rather, ideally, they should be referred in a designated transport like ambulance, where the facilities for oxygen are there, and the staff is also trained to monitor. Yes. And rarely, if we don't have facility and this leading to too much delay, then if parents are healthy, and they are not having any comorbidity, and if they can arrange for oxygen, definitely they can shift the patient, because someone is not going to give a chance for the parents to saturation to drop to such a level that it is not managed.
Okay, thank you.
And in these situations, I think in DSC and SC patients, saturation dips of the baseline, then I think our doctor's colleague, they should give a dose of dexamethasone, shifting prior to the shifting, and it should be clearly mentioned in the discharge summary.
Okay. So this was very important and very, informative talk you have given. I thank you so much.
And if there are no more questions, then I like to thank each and everyone for their patient learning. And if there are more questions, you can put them to my WhatsApp number, and I'll be more than happy to answer to them. Dr. Kaur, I'll share those monitoring chart So you can share with all your treating facilities so that they are very, and they need to be shared with the parents also. And when these children are going for home isolation or home care, we need to discuss with the parents that what are the 3 or 4 things they need to meticulously look into in these children.
After COVID.
Yeah.
Okay. Okay. Thank you so much. So we'll invite you again for another sessions. Thank you so much. Be with us for a long time, and you have spared your valuable time. Thank you.
Okay. So stay safe. Take care, everyone.
Okay.